We're here at the 2016 ESMO conference in Copenhagen, Denmark, and joining me is Stephan Rauh. Stephan, great session, advocacy in action.
Thank you.
Talking about a topic that is really critical, and the topic was palliative care. A lot of interesting conversation. I think there was a lot of consensus on what it is and what it's not, but I'm interested from a clinician's perspective. What did you think of the dynamics in the room and the conversation?
Well, actually, I was very much surprised and very pleased by what I saw, because when I'm working as a clinical oncologist in a community hospital setting, and when I will talk with a patient or his family about palliative care, everyone, even including my colleagues, will think, okay, this is end-of-life care, and this is really bad news. And there is this new WHO definition of palliative care where there is no mention of end-of-life care, because basically what we're trying to do is we try to deal with suffering of the patient, of his family, in any dimension, physical, psychological, at any part of his journey, of his disease. And you might even say, and that was one remark which has been put up by Dr. Timo, and by Dr. Czerny, you might even apply it to disease which eventually will be cured. So clearly we have to inform our patients, our colleagues, about this very important change of mind, I would say, and change of definition, which is absolutely not obvious in the public and outside of advocacy groups and outside of some dedicated specialists. And the second point, of course, is that this change of definition, or this more generous and more general definition, then has to be followed by facts. Right. And we did hear during this session that there is a huge disparity on the access of palliative care. We heard from patients who just did not even have a hint of any psychological support or physical support, pain control. So some of the most basic elements of what we understand by palliative care. This certainly has to change. We have heard some expert opinion from, I would say, very comprehensive cancer, very privileged cancer centers around the world, who have quite a complete team of caregivers with a physiotherapist, a psychologist, but maybe even an arts therapist ready available. I think this is far from being the case around the globe, and we had voices in the public who were telling us this. So we will have to dwell on that. We will have to try to find a way to get this definition into practice around Europe and around the globe.
We heard a lot of emotional comments today. One lady, in fact, you know, didn't receive palliative care. And there's a lot of education that needs to be done, and I think you're hitting on a couple points, that there's some institutions that do it very well, and there's teams, and there's other institutions that don't seem to have the formula quite figured out yet.
Yeah. Well, definitely there's a huge heterogeneity, and there's a demand for specialist training in palliative care, which we do not yet have as a mandatory part of training in oncology. And we also not necessarily, at least not to my mind, in Europe, we do not have recognition, for instance, of palliative care as a specialty. This is, of course, of importance. I would also think that, well, there is a question, and education plays a big role for state of mind. Every caregiver around a cancer patient should be aware of palliative care and should receive education about that. Let me just also state, because that was off microphone after the session, I had a young doctor from a southern European country stating that they did not have a very satisfactory situation in their hospital because there were simply too few doctors just already to deliver the most basic of treatments in the oncology department. So this is often not mentioned, but I do also think, and please forgive me to be biased as a physician, I do also think that the working conditions do play a role, and they're certainly not the same from one hospital to the other. And if you're confronted with 60, 80 patients, then you will have to make a sometimes very ugly triage, and you will be able to afford just a very limited amount of time. So we certainly need education. Certainly we have to educate the public that this is a major goal. We have to have the public educate our governments. Yep. So that the government will give us the means, both through education and infrastructure, to deliver. We have to make it very clear to everyone who starts working in oncology that palliative care should be an elementary ingredient of his formation. And then we have to have also the material, and we have to have the time to sacrifice to our patients properly.